Welcome back, everyone. I'm your lead instructor, Harshal. And before we dive right into today's explainer, I just want to put this out there. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Okay, let's get into it. Today, we're unpacking a really high-stakes financial puzzle. How exactly does a patient's clinical journey dictate a hospital's revenue? If you've ever wondered how healthcare facilities actually keep their doors open after providing weeks of complex care, you're in the right place. We're going to completely deconstruct the inpatient prospective payment system and trace the exact path from a doctor's chart straight to the hospital's bank account. We've got a clear roadmap for today. We'll hit the intro to IPDRG coding, the MSDRG architecture, principal diagnosis versus primary reason, present on admission rules, CDI's impact on revenue, and wrap up with a summary and best practices. Section 1. Let's start with our intro to IPDRG coding. So, how do hospitals actually get paid for inpatient care? Well, let's demystify the core engine of hospital finance right now. There's this huge misconception that hospitals are just sending payers an itemized receipt for every single thing they use, like an a la carte menu where they bill for every bandage, every aspirin, and every minute of a nurse's time. But actually, that is not how it works. Medicare and most major payers use a consolidated prospective payment system. And that brings us to IPDRG, the Inpatient Prospective Payment System Diagnosis-Related Group. Now, the easiest way to think about this is like a giant black box. You feed specific clinical inputs into this box, and it dictates exactly what financial output the hospital gets back. The payment amount is largely fixed and determined based on the clinical and resource similarity of the patient's stay rather than the individual services rendered. This right here brilliantly illustrates that cause and effect relationship. Medical coders look at the patient's chart, grab the diagnostic and procedural codes, and feed them into a piece of software called a DRG grouper. So you input the principal diagnosis, secondary comorbidities, major procedures, and demographics. Then boom, the software outputs the exact MSDRG, the relative weight or severity of the case, and the final payment amount. Getting this coding exactly right is absolutely crucial. It literally dictates reimbursement, compliance, and quality scores. Moving on to Section 2, let's look at the MSDRG architecture. So let's look under the hood and see how this engine actually organizes thousands of complex medical codes into something manageable. Imagine a giant funnel. Cases are funneled into one of roughly 750 distinct payment groups. First, they get sorted into one of 25 major diagnostic categories, like the respiratory or circulatory system. Then, the system asks, did a major surgery happen? That splits them into medical or surgical. Finally, they get tiered by severity into triplets. And this is key, that tiering relies entirely on the presence of secondary diagnoses, which we call CCs, complications or comorbidities, and MCCs, major complications or comorbidities. Now, check out how this severity logic drives the actual math. The payment formula is basically your hospital's base rate multiplied by the DRG relative weight. For instance, a simple heart failure case is going to have a fairly low relative weight. But what if that heart failure is accompanied by an MCC, something major like acute renal failure or sepsis? Suddenly, that relative weight shoots way up, significantly increasing the reimbursement. And that makes total sense, right? It reflects the immense resources the hospital had to use to treat that much sicker patient. Section 3. Let's talk about principal diagnosis versus primary reason. To get that DRG correct, we have to establish exactly why the patient is actually in the hospital. And honestly, this is a massive point of confusion, even for seasoned pros. There is a huge difference between the primary reason for admission and the principal diagnosis. The primary reason is just the chief complaint when they walk through the door on day one, like, say, severe chest pain. But the principal diagnosis? That's the condition established after study to be chiefly responsible for the admission, like a heart attack. If your coder just uses the initial symptom of chest pain instead of the established diagnosis of a heart attack, the entire DRG is wrong, the case goes into the wrong category, and the hospital is severely underpaid. All right, Section 4, present on admission rules. Let's add the next layer of complexity, which honestly acts as a massive financial safeguard for payers. We're talking about present on admission, or POA rules. Whenever a diagnosis is coded, it has to have a POA indicator attached to it. The coder literally has to comb through the chart and flag whether a condition was brewing before the patient arrived, that gets a Y for yes, or if it happened well under the hospital's watch, which gets an N for no. There are also flags for when documentation is insufficient, clinically undetermined, or just exempt. This right here is the ultimate butterfly effect of medical coding. Because of specific CMS policies, if a patient develops a complication during their stay, meaning the POA flag gets marked as an N, CMS considers it a hospital-acquired condition, or HAC. And here's the kicker. That complication can no longer be used to increase the IPDRG payment tier. So missing or incorrectly applying a POA status can immediately wipe out the financial weight of an entire resource-intensive complication. Which perfectly sets up Section 5, CDI and revenue impact. This is really the climax of how all this works. Because precision is so vital, clinical documentation improvement, or CDI, acts as the ultimate defender of a hospital's revenue integrity. CDI specialists are the bridge between the clinical staff and the coding staff. They review these medical records concurrently while the patient is still in the bed. When a doctor's note is vague, like maybe they just write history of stroke instead of history of cerebral infarction due to embolism, CDI specialists jump in. They send formal queries to the physicians to make sure the record actually supports the true severity of care. This prevents DRG downgrades and those devastating payer denials. Let's actually look at a real-world scenario here. This is a perfect example of how specific documentation and POA logic completely shift the financial reality for a facility. Imagine a patient is admitted for sepsis. Now, they also have diabetic ketoacidosis that was present on admission. That DKA acts as a major complication, so the relative weight is high, let's say 1.9015. Great. But what if that exact same patient develops a deep vein thrombosis, a DVT, 2 days into their stay? Because it happened after admission, the POA flag for the DVT is N. Even though a DVT is a major, serious complication, it's now officially a hospital-acquired condition. The payer is going to completely ignore that DVT when calculating the DRG payment, and the hospital might even face a penalty. See how simply catching whether something was present on admission versus hospital-acquired shifts the entire financial reality?
Let's wrap things up with Section 6, Summary and Best Practices.
Okay, let's synthesize all of this into some actionable takeaways. The collaboration between the physician's pen, the coder's analysis, and the CDI specialist's query is really the only way to ensure the DRG accurately reflects the patient's severity. You have to demand specificity. Don't just accept pneumonia. Push for pneumonia due to Klebsiella. Always ensure laterality is there for procedures, left, right, bilateral. Meticulously verify POA status, and use those CDI queries constantly to clear up ambiguities. Most importantly, ensure the history and physical, progress notes, and the discharge summary all tell the exact same clinical story. Undercoding loses revenue, and upcoding triggers audits. You have to thread the needle. It's a high-stakes puzzle, guys. Every single word a physician writes translates into a code, which translates into a DRG, and ultimately becomes the lifeblood of the hospital's financial health. So, I want to leave you with this to chew on. If your facility's documentation was audited today, would your clinical narrative accurately justify your revenue? Think about it. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. Thanks for hanging out with me on this explainer, and I'll see you in the next one.